Good morning. This is the voiceover PowerPoint for Chapter 18. Pardon me, my voice is a little iffy this morning, so I hope that this goes well. All right, so we're going to talk about pain management during labor and delivery. And we've discussed pain before in previous classes. We always know that the pain is what the patient says it is. But in childbirth, it's kind of different because it's a normal process. It's part of how babies are born. And, women know that in labor they're going to have discomfort and or pain. But the end of it is the baby is born, and after a while, everything sort of goes back to normal, and they say the pain is forgotten, although I don't know if that's entirely true. But it's very subjective and very personal, as we know. Now, these are just some pictures that I found quite a while back, but they are very good and they're pretty accurate here. You can see how the different areas or regions, if you will, of the pain begins. And you see their letter A is during the first stage there, letter B. As letter A never goes away, it's just got an additional oreas. And C could be the second stage in actual birth. There's pain in the back, and especially if the baby is coming occiput posterior, which means the widest part of the head is trying to come first, and it causes a lot of back pain, and babies typically come more face up, and so they may have some, look like their face is a little mashed, but it goes away, obviously. It gets better. So these are the sources of pain that occur during childbirth. I'm sorry, my voice. Tissue ischemia, that just makes sense. Labor, contractions, there's going to be some lack of blood flow possibly. It's temporary. Cervical dilation can be quite uncomfortable. And then the pressure and the pulling of the pelvic structures, the pelvic floor, the muscles, the tendons, and so forth. And then, of course, as the baby is crowning and the head is being born, the distension of the vagina and the perineum will be very obvious. And if the woman has had an epidural, she typically does not feel this. But a woman maybe who has not had epidural may experience this up until the time maybe they do a local block in the perineal area. So you have some circumstances that may change this slightly. So here are pain transmission pathways with the different levels of the vertebrae and the nerve endings. And there's pain stimuli from the vaginal and perineal distension travel through the pudendal nerve. That's important. You'll hear that pudendal again, nerve, and enter the spinal cord at these segments. So the pudendal nerve is a pretty important one, and you'll hear that again when we talk about some of the anesthesia. We'll be talking about a pudendal block in a while. So we know that different people perceive pain different ways. Of course, factors that influence the perception of pain might be physical influence, how intense or how strong the contractions are, how quickly things are moving, the fetal position and size. Contrary to belief, a small fetus, a smaller baby is not necessarily easier to give birth to. It all depends on the powers. Remember those 5 P's, the powers, the passageway, all those things come into play, not just the size of the fetus, although that can be an element, of course. How well the woman's pelvis can adapt to the baby, and they may have determined earlier in her pregnancy that her pelvis does not lend itself to a vaginal birth, which can happen with maybe congenital issues and so forth. And so they may decide early on that they're just going to schedule a C-section. So those are all other things. Fatigue of the mother. The mother gets tired. She's been doing this a long time. She wears out. And then, of course, the interventions that we give to our patients, helping them manage their pain, can have a huge impact on their perception of their pain being managed. We always want to say manage pain. We don't want to say get rid of your pain because we really cannot guarantee that. But we certainly want to use words like we're going to help you through the pain, we're going to help you manage your pain so that it won't overwhelm you. Those kind of phrases really do help. Psychosocial factors can also influence a woman's perception of pain. Psychosocial factors like culture. Some cultures, they're very verbal with their expressions of pain. Other cultures are very stoic, which means they have a very flat affect. They don't let anything show. They don't scream. They don't holler. They internalize it. Of course, a first-time mother especially, or maybe a mother who's had a child or two before and maybe had a terrible birth experience, could be very fearful and very anxious. And of course, the first-time mama will, despite the fact that we have a lot of information available and, prenatal classes and birthing classes, all those are great, but they still don't completely get rid of possibly some feelings of anxiety and fear. Again, previous experiences with pain or maybe watching a loved one have a bad experience can stick with you. Their preparation for childbirth, are they informed? Have they had prenatal care? Do they kind of have an idea of what to expect? Do they ask questions? Do they have a birth plan? Because we want to know their birth plan. If they don't want to have an epidural, we want to support that, and that they change their mind, we want to support that as well. And of course, a laboring mother needs to have some sort of support system. A spouse, a significant other, a parent, a sibling, somebody there, a close friend, someone there to help them and support their experience. So we want to try to manage pain if we can begin with and continue to use non-pharmacologic pain management. We just don't want to slap people with medicine because remember, we've got a baby to think of. So we have to be cautious with our measures. We just want to make sure that we provide comfort to the mother. That could be warm blankets. That could be keeping the bed clean. There can be a lot of mucus and bloody show and amniotic fluid, and sometimes women are incontinent. We want to keep those pads and all that stuff underneath her clean and dry. Clean her perineal area, always front to back, we know that. All those general comfort measures, keeping her repositioned, pillows, ice chips, fans if they're hot, etc. Just the general comfort measures. Helping them by explaining things about what's going on, what kind of things we are going to anticipate next. That may help reduce anxiety and fear and encourage them to relax, especially between contractions. Let it, help them breathe deeply and so forth. There's guided imagery, there's hypnosis, there's all kinds of things that people use to try to work through their pain, through their labor pain. Some women come all prepared. They've had Lamaze, they've had prepared childbirth classes. They think they got it all together, but when the pain really hits, some of that knowledge goes out the window. And so we kind of have to help bring them back and help them deal with their issues. So, be open-minded. Sometimes it may seem a little strange to you, but if it works for her, it's great. Pharmacologic pain management, we have to consider the effects on the fetus. So we know if we give an opioid to mama, it can make her sleepy, could make her respiratory drive a little less. Guess what? Same thing with baby. Baby's going to be sleepy. We give pain medicine close to delivery time, that baby's going to be sleepy and the Apgar is not going to be too good. They'll be okay, but you have to do a lot more resuscitative measures. Of course, we know about a lot of the pharmacologic pain management. I'm speaking specifically of opioids. There's other non-opioids that we can use, but remember, we still have to consider the effects on the fetus. So we give smaller doses, maybe more frequently, or we wait at the end. We don't load up the mama with lots of pain medicines when it's getting close to delivery, because we will have a respiratory depressed infant. And so sometimes these pain measures that we use can help speed labor along because they do relax mama, and maybe everything is relaxed and maybe that cervix opens up and away we go. Sometimes it'll do the opposite. It will slow labor down. So we could go either way. And then of course If there's any pregnancy complications, we always have to take that into consideration. And then, of course, if we don't know, or even if we do know that mama used meth 2 days before she got in labor, we would want to take that into consideration. And sometimes we know those things, and sometimes we don't. So we have to be prepared for anything unusual here. So we have different types of regional, okay, wherever the pain is the region or the area. We have regional anesthesia, which is mostly the perineal area and the coccygeal area. The pudendal block we talked about. Local infiltration anesthesia, that's just like a local in the dentist office, or a local to sew up a laceration. It's just in the perineal tissue. Hi, kitty. My cat's in here with me. And then we have the epidural, which we all are fairly familiar with. We can use a combined spinal epidural if need be. A subarachnoid block, I have not seen one of those used in a long, long time, so I wouldn't even worry about that. I would worry about the others. You need to remember this. This is very, 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 very important. This slide is very, very important. The adverse effects of an epidural, while they're great and they work well and we generally have pretty good outcomes with them, we have to remember that one of the bad side effects or adverse effect of giving an epidural is it will knock mama's blood pressure down. So typically what we do before we give the epidural, before we place the epidural, we place the epidural and before we load it up with medicine, we'll give mama a bolus of IV fluids. Remember, a bolus is a larger amount in a short amount of time, maybe 250, 500 milliliters bolus, and then we're going to really keep an eye on that blood pressure. It can cause bladder distension because they don't always feel the urge to urinate, and so their bladder gets distended. So we really need to keep a watch on that because that can impede labor, and it can be kind of dangerous if we let the bladder get too full. Sometimes the epidural catheter can migrate or get out of place. That's pretty unusual because they secure it pretty good, and they can get some fever afterwards, although that's not quite as common. Now we can also give, in addition to things like lidocaine, bupivacaine, any of those canes that we use for local anesthesia, they can also give through the epidural catheter some opioids like a little dash of fentanyl, something like that. But the bad thing about it is lots of times it makes mama nauseous and it makes mama itch. So lots of times after they've had the epidural, they'll be itching. They may, after the baby's born especially, they'll give them a little dose of Benadryl, and that usually takes care of it. And of course, nausea and vomiting, we're going to give them some Zofran. So here's the local, okay? All this is doing is maybe the epidural is starting to wear off, and doc is, sewing up a laceration or, an episiotomy, whatever, and she's like, ouch, I feel that. Okay, well, we'll get a little local anesthesia, lidocaine or something like that, and just inject it into the area of where we're working, the stitch area, and that will help with that pain. Just a small amount, no big deal. The pudendal block, remember we talked about the pudendal nerve, numbs the whole perineum, okay? And so a lot of women who opt not to have an epidural will often have a pudendal block. And you see here how it's given. I'm not even going to try to explain this to you. I haven't seen these used for a while, but we used to use them a lot. But you can see there the area, the pudendal nerve and the ischial spine and all that. The doc does this, or the nurse midwife. I don't think they do these. CRNA could, but again, they're not very common. The previous slide, the local infiltration, is probably more common. But we have to do this pretty late in the labor. She may be close to crowning, or maybe even a little bit before. We'll give this and numb her up, and then she'll be able to, she can still feel her contractions, and she'll have pain with that, but the perineal area will be very numb. Okay. So the epidural is currently the most effective pharmacologic pain relief method for labor. You can see here the combined spinal epidural, walking epidural, although I don't see that used very, very much because a lot of women says it makes them feel kind of woozy and they're scared to get up and walk around. So, pardon me, the epidural is usually the most common. Okay, so you can imagine, let's look at letter A. Now this shows the woman lying down with her knees up. Imagine her great big pregnant belly trying to do that. Most of the time I see him having her sit on the edge of the bed and crouch her back, round her back out, because that will open the space up where they need to thread the epidural needle and catheter. And then the other pictures below, B, you can see her sitting up on the side of the bed. They've got her draped. They've got where they're going to place the epidural catheter. And then letter C is the epidural is placed. You see how it's taped. And then they bring the outside of the device up over her back to her shoulders. And there's a little stopcock, a little port there that if they need to put more medicine in it, they can just do it from that area and not have to re-stick her or anything like that. As the nurse, it's your job to help her breathe through her contractions, help her maintain that position, because if she moves, that could be a big problem, because most epidurals are without any problems. Some people say, oh, after you have an epidural, your back will never be the same. That is not true, unless you have someone who's very incompetent and doesn't know what they're doing, doesn't place it correctly. But most of the time they're very safe. But our job is to help her maintain that position and help her with her contractions. And then once it's in, she will lie down and they will give her the medicine. Also remember that you have to have a signed consent for an epidural, and the anesthesiologist's job is to go in and explain things to the mother and get that informed consent, not the nurse. So here's the levels of where they place the epidural and or spinal. The spinal, of course, is a little bit higher up. Lots of times they may do a spinal if they have a scheduled C-section. Some docs prefer those over the epidural. Sometimes it's just a doctor preference. And you see there where they go in between the spaces, the subarachnoid spaces for the spinal, which, they can use those, but not quite as much. And then, of course, the epidural, you can give a continuous or a single dose. It just depends on your situation and what you're trying to do. We do not make that judgment. The physician does that. Okay. So here's the levels of anesthesia for a C-section and the levels of anesthesia for a vaginal birth. So the C-section, as you see, can go all the way up to almost up to the diaphragm. And sometimes if they get it too high, women will really get short of breath and they'll have some difficulty and they have to have some oxygen. And then you see the bottom there, typically from the lower abdominal area and on down, you see that their feet and legs are affected as well. So that's why it's important after the spinal or the epidural, the baby's born, we take the epidural out. We have to make sure that mama gets sensation back, and a spinal too, gets sensation back in her lower extremities before we ever try to get her out of bed, because she'll fall. And you'll have a real problem on your hands. Okay. So this is a slide that I put together with other information here, but it's very, very true. And I believe it's the same stuff that's in your book, maybe not verbatim, but very, very close. They have to have a signed consent for an epidural. We want to check the platelet count, and we should have done that when the lady came in, or maybe we have her most recent prenatal records where she had a CBC. We know her WBC, we know her hemoglobin, hematocrit, and we want to know platelets, because remember, platelets help with blood clotting. If we happen to get in there and nick a vessel in that spinal cord, that could be really, really bad. And so we don't want to do that. If the platelets are less than 150,000, she cannot have an epidural. She cannot. So we don't want to know that. We want to make sure that the patient's bladder is empty. Make sure your IV site is good before we ever start this. Sometimes they'll have 2 sites, but most of the time it's just one. Make sure that IV is good. Most of the time they prefer an 18 gauge needle if we can get it in there. 20 at the minimum. Okay, 18 is better. A fluid bolus, 250, 500 milliliters prior to giving the epidural. Keep that blood pressure up. Make sure you've got a blood pressure cuff on that arm. And, of course, you're probably going to have maybe a O2 sat monitor, which will give you your sat and your heart rate. And, of course, your baby's going to be being monitored all the time. Or watching that fetal heart rate, because it can have some effect on that. Once we have it inserted, we'll have her lie on her back. And we don't want to put the head of her bed up too much, because then all the epidural will run down toward her feet and she won't have any in the abdomen. So about maybe 10 to 15 degree elevation of the head if necessary. Make sure that we're watching that blood pressure. Sometimes we'll lay her flat, but we'll put a wedge under her back to keep her off the vena cava. Watch her fetal heart rate. It may relax the patient and labor may progress, or it can slow her down. So if she slows down and she's not on PIP, they may give her a little Pitocin to help her out. And you're always wanting to check the level of sensation. And sometimes women get what they call hot spots, where one side of their abdomen maybe, they can still feel the contractions. And so you need to let anesthesia know that, and they may come back and do something, and they may just say, no, she's going to have to deal with it. But it happens sometimes. It doesn't always go exactly as planned, unfortunately. So contraindications to these could be active or anticipated serious maternal hemorrhage, obviously. Maternal hypotension that does not respond to fluids, okay? We already know she's got low blood pressure for whatever reason. We don't want to add to that. Maternal coagulopathy, check the platelets, we said. Infection at the injection site, that's rare, but it can happen. That's why it's a sterile procedure, and we make sure we get everything cleaned and all that. It can cause increased intracranial pressure, although it's pretty rare. Sometimes they have an allergic reaction to anesthetics, but again, that's rare. We always ask those allergy questions, of course. Sometimes the mother cannot concentrate or cooperate, or she just doesn't want it, so obviously we are not going to force her. And then sometimes certain cardiac conditions, and this is determined by the physician, maybe she has some issues with heart valve problem, or maybe some heart failure because she had congenital heart. It's all kinds of things. Again, we would not make that decision. That would be the physician. But we definitely want to check those platelets. That's very, very important. So other things that can be used for labor pain management is inhalants. A lot of places use nitrous oxide, and that's, some women think that they work well, okay? Opioids and opioid antagonists and other adjuvant drugs and sedatives are all used possibly. Most of the time, lately in my experience, everybody pretty much relies on the epidural, but you know, we always have these. Just remember, when you use an opioid, it's going to cause respiratory depression in mama, and it can in the neonate. The others are not quite as bad as that, but just remember, what mama gets, baby's going to get to a certain extent. So we have to just keep those things in mind. And I believe these drugs are listed in your book. I didn't put them on this slide, but you can read those in your book. Worst case scenario. Worst case scenario. Mama cannot have an epidural. She has to have an emergency C-section. She's got to have anesthesia. We'll use general. Worst case scenario. We don't like to give general anesthesia to mamas about to have babies, because guess what? The baby comes out very anesthetized, okay? So we'll do this. In my experience, what they do is, if it's an emergency, they take her right to surgery. They get everything ready, and then they put her under and immediately get that baby out as quickly as they can. Unfortunately, with mothers, they can have aspiration, because maybe they've been eating or drinking, and they can still aspirate. And of course, one of the effects of general anesthesia, regardless if you're pregnant or not, can be respiratory depression. So we try to minimize risk. The maternal aspiration, lots of times they'll give them Bicitra, or maybe, let's see, Bicitra, or maybe, I can't think. Something to help minimize aspiration. And respiratory depression, we're just going to give her the minimal amount of anesthesia, and as soon as we can, we're going to reverse it, and that's the anesthesiologist's job, or CRNA, whatever it might be. And then when we are recovering her after this, we are keeping a very close eye. Number one, airway, her heart rate, her blood pressure, all those things. And of course, we still have to watch for bleeding. We still have to watch for keeping that fundus firm. So regardless of how we're doing all this, once the baby comes, we still have to do all the postpartum checks that we've talked about before.